Hi everyone, I am Marica Iommi, a PhD student at the University of Bologna, and today I'd like you to talk about comparing risk adjustment estimation methods under regional data availability constraints. In this paper, we develop a framework for designing an effective risk adjustment model to predict total healthcare expenditure by using routinely available person-based Italian data and exploring different data scenarios that Italian regions may face. We also examine how the predictive performance of standard and machine learning techniques vary across data granularity and range of variable settings. A country, especially those with a federal health system, may face data constraints to develop an effective risk adjustment model to predict individual healthcare costs. Therefore, policymakers should optimize their data availability in the short-medium term, pending an improvement in the granularity or enrichment of the range of variables of their data. Regions or countries with data constraints may use our framework to optimize the information available to allocate resources or reduce the risk selection with the best performing model. For countries with national health systems, this study may serve as a basis for budget setting using regression model, which are more predictive than synthetic index or actuarial self-formulas because they capture more patient variability. Additionally, countries with sophisticated healthcare systems may consider implementing newer techniques such as machine learning to achieve a simplified and more parsimonious model to reduce the possibility of gaming with diagnostic upcoding, as well as to analyze large and complex databases with thousands of covariates to explain an health outcome, as standard statistical methods may not be suitable or feasible. The predictive performance of risk adjustment models depends significantly on the explanatory variable used. Differences in data collection stem from several sources, including the accessibility of distinct databases in different healthcare areas, such as inpatient, pharmaceutical, or outpatient services, the range of data elements collected within a healthcare area, the ability to merge information at individual level due to privacy regulation, and eventually the different quality standards or level of detail in data collection according to the local context. The Italian NHS has the potential for using a highly detailed and wide-ranging set of healthcare information to predict the individual expenditure. However, data collection takes place at local level, leading to heterogeneous information systems and variabilities in data granularity and quality control across regions. Despite this potential richness of individual health information, the allocation of Italian NHS resources to regions is still based on capitation and partially on age-weighted capitation. A review of the allocation criteria was discussed in 2016 in the Italian Conference between State and Region, but no specific proposal have been implemented yet. So, this table describes the 6 data scenarios we considered, which varies in 2 dimensions. We use a range of variables to refer to the data availability with respect to different health areas. And with data granularity, we refer to the detail of information available. In the coarse granularity and poor range of variables, there is the simplest risk adjustment situation. Age and sex are optimal exogenous risk adjusters because they cannot be influenced by individuals or providers' actions, although they are not highly predictive of healthcare expenditure and lead to elevated level of risk selection. Consequently, since the late 90s, the United States and many European health systems expanded the range of variables to reduce risk selection with increasingly sophisticated risk adjustment models, adding to in socioeconomic, pharmacy, and diagnosis-based indicators.
The Italian health information system is theoretically located in the cell at the bottom right, but as long as the reliability and consistency of the administrative databases is uncertain, the first cell at the top left could be the first plausible scenario in the transition from synthetic index to regression models. The study population is the 2016 Emilia-Romagna population, a northern Italian region with about 4.4 million individuals with universal access to the Italian NHS. The socio-demographic characteristics considered in the analysis were gender, age, divided into 20 classes, citizenship, which is Italian yes or no, the degree of urbanization, classified into sparsely, intermediate and densely populated areas, and income. From hospital discharge record, we retrieved the number of hospitalization and the ICD-9-CM codes used to develop the diagnostic cost group. From outpatient pharmaceutical database, we retrieved the anatomical therapeutic classification codes employed to develop the pharmacy cost group. The linkage among these databases was possible through a unique anonymized patient identifier, and the dependent variable was the sum of hospital, pharmaceutical, and the outpatient care services expenditure. A concurrent risk adjustment approach was used. For standard techniques, we mean ordinary least squares, which is the main tool used in practice, and generalized linear model, which have been used to account for the highly skewed distribution of healthcare cost. Recent literature has explored the application of machine learning techniques to risk adjustment formulas, especially in health systems with fine and rich range of variables. Machine learning methods allow to manage the complex structure of population-level health data. Penalized regression, that is loss ridge regression and elastic net, can reduce variance by adding a penalty function to the usual residual sum of squares. They are more parsimonious because they tend to select only the most predictive variables. We also implemented random forests, which is a non-parametric ensembling method, and its strength is that it may find non-linearities, such as interaction between predictors. Finally, we built a superlearner, an ensembling method that takes a weighted average of predictive values from underlying machine learning algorithms to produce a single best prediction function. We divided the population into a 70% training set and 30% of test set. Model fit was judged using the adjusted R-square, MSE, and the mean under overcompensation by quintile. The relative efficiency of each algorithm compared to OLS was evaluated. These figures report the best and the worst performing model compared to OLS. The superlearner had the best performance in all scenarios, except in the first one in which the lasso had the best performance. In the coarse granularity poor range of variable settings, all models had similar result. In fact, the relative efficiency was 1 across all models. Focusing on the adjusted R-square, the gain in relative efficiency compared to OLS was higher in the coarse granularity rich range of variable and in the fine granularity poor range of variable settings, and it was equal to 1.03. The lowest adjusted R-square of OLS was 4.3% in the coarse granularity poor range of variable, while the highest was 48.5% obtained in the coarse granularity rich range of variable data. We obtained inconsistent values for the GLM, denoting their poor performances. Concerning mean square error, in the coarse granularity poor range of variable and in the fine granularity fair and rich range of variables, the gain of relative efficiency was particularly minimal compared to OLS, less than 0.01. Gains in implementing machine learning techniques were higher in the coarse granularity fair range and rich range of variable scenarios, where superlearner reduced the mean square error by 2.1 and 2.6%. This graph shows the mean under and overcompensation for healthcare expenditure by quintile. In the Scenario 1 and Scenario 4, all models highly overcompensate the expenditure of the individual in the 4th percentile group, while in the 5th quintile group, all models highly undercompensate. However, when the range of variables increases, the 5th percentile group is, in a lesser extent, overcompensated, mostly in the coarse granularity rich range of variable scenario and less in the coarse granularity fair range of variable scenario. In Scenario 3, we also see the lowest mean under overcompensation relative to the other scenarios of the 1st percentile group. Our findings show that machine learning techniques, particularly superlearner, outperform OLS in all data scenarios, with a minimum gain in the coarse granularity poor range of variables to a maximum gain in the coarse granularity rich range of variables. The choice of the model depends crucially on the performance measures. Thus, it is of foremost importance to compare various measure fit and interpret the results very carefully. It is more appropriate to rely on the adjusted R-square and mean square error to overall maximize the variance explained and reduce the prediction error. However, if the primary goal is to minimize the differences between the predictive values and the observed values in specific groups that may be at risk of selection, and to incentivize cost control, then the under-overcompensation and the predictive ratios are more suitable. Policymakers should consider other evaluation criteria in designing the risk adjustment model, in addition to model's predictive performance, such as availability of data, appropriateness for incentives, for risk selection, and efficiency. From an operational perspective, machine learning techniques increase variance explained by the model, explore possible interaction terms with the automatic process, and they may decrease risk selection and upcoding action by selecting few important variables over all possible covariates. But if the differences are considered negligible, and the investment too onerous, then the OLS can be used with large populations. To summarize, it is well known that in designing a risk adjustment model, it is important to evaluate not only the predictive performance, but also the trade-offs with adverse economic behavior. Thank you very much for the attention.